Hypoxic-Ischemic Encephalopathy stands as one of the most significant causes of acute brain injury in newborns, affecting 1 to 2 per 1,000 live births in Western countries. In developing nations, where obstetric resources remain limited, this incidence climbs substantially higher. Understanding HIE begins with recognizing what we're actually observing clinically. HIE describes abnormal neurologic behavior in the neonatal period following perinatal hypoxia-ischemia. The significance becomes clear when we consider that HIE accounts for 25 to 45% of all neonatal encephalopathy cases, establishing it as the leading cause of acute brain injury in term infants. The historical perspective reveals why this condition has commanded such intense research focus. Before therapeutic hypothermia became standard care, the chance of irreversible damage or death after severe perinatal asphyxia reached devastating levels of up to 65% in patients enrolled in neuroprotective trials. Think about the clinical reality this represented. Nearly 2/3 of affected infants faced death or severe lifelong disability. Therapeutic hypothermia fundamentally transformed these outcomes. Evidence from multiple randomized controlled trials demonstrates that we've reduced death and disability to approximately 45%, still substantial, but representing a dramatic improvement. The Cochrane meta-analysis, including 1,505 term and late preterm infants with moderate to severe HIE, shows therapeutic hypothermia results in fewer deaths, with mortality dropping from 34 to 25%. This improvement translates directly to clinical practice. The number needed to treat to prevent death or moderate to severe neurodevelopmental disability in one newborn is 7, making therapeutic hypothermia one of the most effective interventions in neonatal medicine. Understanding this evidence base shapes how we counsel families, allocate resources, and structure NICU protocols for optimal neuroprotective care. Precise terminology determines clinical recognition, treatment timing, and prognostic accuracy in NICU practice. Hypoxia describes partial oxygen deprivation to brain tissue or blood, while anoxia represents complete oxygen absence. This distinction carries clinical significance because partial oxygen reduction allows some cellular metabolism to continue, potentially preserving neural function if we correct the condition rapidly. Hypoxemia specifically refers to inadequate oxygen levels in blood, which we can measure directly through blood gas analysis and monitor continuously through pulse oximetry. Ischemia involves reduction or complete cessation of blood flow to organs like the brain. This process compromises both oxygen and essential substrate delivery, particularly glucose that brain cells require for metabolism. Global ischemia results from reduced cardiac output during circulatory failure, affecting the entire brain. Focal brain ischemia, or ischemic stroke, has become increasingly recognized in both term and preterm neonates through advanced MRI techniques, which serve as sensitive methods to demonstrate stroke patterns. Perinatal asphyxia derives from the Greek word for suffocation and describes interrupted placental and umbilical cord oxygen supply to the fetus. This creates combined hypoxemia and hypercapnia. When total oxygen interruption occurs, anaerobic glycolysis begins within minutes, producing lactic acidosis and measurable metabolic acidosis through blood gas analysis. Fetal bradycardia develops simultaneously, adding ischemia to the hypoxic insult and augmenting cerebral compromise. Understanding how these mechanisms interconnect explains the complex pathophysiology we observe clinically. Hypoxia can transition to ischemia. Asphyxia combines multiple insults, and recognizing these patterns guides therapeutic approaches in NICU care. Primary energy failure represents the immediate cellular catastrophe that occurs when oxygen delivery to brain tissue becomes critically compromised. Within minutes of hypoxic ischemic insult, cerebral perfusion drops and oxidative metabolism fails. The cellular machinery depends entirely on adequate oxygen for energy production. When hypoxia develops, cells rapidly shift from efficient oxidative phosphorylation to anaerobic glycolysis. This metabolic switch produces far less ATP while generating excessive lactic acid, creating both local and systemic metabolic acidosis that we can measure through blood gas analysis. The cascade accelerates when fetal bradycardia develops during the hypoxic insult. bradycardia adds ischemic injury to the existing hypoxic stress, creating the combined insult that defines perinatal asphyxia. The reduced heart rate significantly decreases cardiac output and further compromises cerebral blood flow. At the cellular level, ATP depletion triggers a devastating sequence. Energy-dependent sodium-potassium ATPase pumps fail, causing membrane depolarization and uncontrolled calcium influx. The excessive intracellular calcium activates destructive enzymes including lipases, proteases, and endonucleases, which begin breaking down essential cellular components. Excitotoxicity develops as glutamate accumulates in synaptic spaces. Without adequate ATP to power glutamate reuptake mechanisms, this excitatory neurotransmitter activates NMDA receptors, causing even more calcium influx and perpetuating the destructive cycle. Understanding primary energy failure explains why time becomes so critical in neonatal resuscitation. The longer this process continues, the more cellular damage accumulates. Successful resuscitation must restore oxygen delivery and cardiac output quickly to halt this progression before irreversible neuronal death occurs. This knowledge directly informs the urgency we maintain during neonatal emergencies. Secondary energy failure represents a paradoxical phenomenon where successful resuscitation and reperfusion actually trigger delayed neuronal death. This phase occurs between 6 to 48 hours after the initial insult and creates the therapeutic window that makes hypothermia effective. During the latent phase between primary and secondary failure, cellular metabolism partially recovers. ATP levels improve, cytotoxic edema resolves, and cerebral oxidative metabolism appears to normalize. This apparent recovery can mislead clinicians into thinking the infant has escaped significant brain injury. However, reperfusion itself becomes problematic. The restored oxygen delivery paradoxically generates massive quantities of reactive oxygen species and hydroxyl radicals. The immature neonatal brain lacks well-developed antioxidant mechanisms, making it particularly vulnerable to this oxidative assault. Free radical production occurs primarily from brain arterial endothelium through xanthine oxidase activity. Mitochondrial dysfunction becomes the central mechanism driving secondary energy failure. The organelles that should restore normal cellular energy production instead become sources of continued damage. Mitochondrial membranes suffer oxidative damage, leading to release of cytochrome C and activation of apoptotic pathways. The inflammatory cascade intensifies the injury. Pro-inflammatory cytokines, including interleukin-1, 6, and 8, along with tumor necrosis factor alpha, flood the brain tissue. Microglia become activated, releasing additional toxic mediators. The blood-brain barrier becomes permeable, allowing peripheral immune cells to enter brain parenchyma and contribute to ongoing tissue destruction. Excitatory amino acids, particularly glutamate, accumulate again during this phase. Combined with ongoing free radical production and inflammatory mediator release, this creates a complex neurotoxic environment that can persist for days after the initial insult. This pathophysiology explains why therapeutic hypothermia must begin within 6 hours of birth. The intervention targets these secondary mechanisms before they fully develop, providing neuroprotection during the most vulnerable period. The fetal diving reflex represents an evolutionarily conserved response that attempts to preserve vital organ function during severe hypoxic stress. This physiologic adaptation prioritizes blood flow to the brain and heart at the expense of other organ systems, creating the characteristic multisystem involvement we observe in HIE. During experimental asphyxia, blood flow redistributes dramatically. Cerebral and cardiac perfusion receives priority, while renal, hepatic, and gastrointestinal circulation becomes severely compromised. This redistribution explains why almost all infants with clinically significant HIE demonstrate compromise in at least one organ system beyond the brain. Cardiac dysfunction develops in 75 to 100% of infants with HIE. Myocardial contractility becomes impaired, causing reduced cardiac output and hypotension that further compromises cerebral perfusion. Echocardiography reveals acute cardiac dilation, functional tricuspid valve regurgitation, and myocardial ischemia, Cardiac biomarkers including troponin T become elevated, with abnormalities present in up to 90% of affected neonates. Acute kidney injury occurs in 23 to 70% of asphyxiated infants. The redistribution of blood flow away from renal circulation leads to acute tubular necrosis and oliguria. Rising creatinine levels and poor urine output indicate significant renal compromise that affects medication clearance and fluid management. Hepatic dysfunction appears in 80 to 85% of cases during the first week after birth. Elevated liver enzymes reflect hepatocellular injury from compromised perfusion. This dysfunction impairs synthesis of clotting factors and affects metabolism of medications commonly used in critically ill neonates. The syndrome of inappropriate antidiuretic hormone secretion commonly develops, leading to hyponatremia and fluid retention. Disseminated intravascular coagulation occurs frequently, with thrombocytopenia and elevated D-dimer levels, indicating widespread activation of the coagulation cascade. Understanding this systemic involvement guides comprehensive management strategies. Successful treatment requires addressing not just the neurologic manifestations, but also supporting cardiac function, managing renal impairment, correcting coagulopathy, and monitoring for metabolic derangements that can exacerbate brain injury. Understanding the diverse causes of fetal hypoxic-ischemic insults helps clinicians recognize risk patterns and implement preventive strategies. The evidence shows these causes fall into 3 distinct categories, each disrupting oxygen delivery through different mechanisms. Maternal causes create systemic compromise that directly affects placental perfusion and fetal oxygenation. Cardiac arrest represents the most severe maternal cause, completely eliminating maternal circulation and thus placental blood flow. Severe anaphylaxis triggers massive vasodilation and cardiovascular collapse, while status epilepticus creates prolonged periods of maternal hypoxia and acidosis. Maternal asphyxiation from conditions like drowning or suffocation directly reduces maternal oxygen saturation. Hypovolemic shock from hemorrhage or severe dehydration compromises cardiac output and placental perfusion pressure. Uteroplacental causes interrupt the normal flow of oxygenated blood between mother and fetus. Placental abruption physically separates the placenta from the uterine wall, severing maternal-fetal circulation. Cord prolapse compresses the umbilical vessels, creating acute interruption of fetal circulation. Uterine rupture can compromise both maternal circulation and direct fetal blood flow. Hyperstimulation with oxytocic agents creates excessive uterine contractions that compress placental blood vessels and reduce placental perfusion during contractions. Fetal causes originate within the fetal circulation itself. Fetomaternal hemorrhage creates acute fetal blood loss and hypovolemia, reducing fetal cardiac output. Twin-to-twin transfusion syndrome in monochorionic pregnancies creates severe volume imbalances where one twin becomes plethoric while the other develops severe anemia. Severe isoimmune hemolytic disease causes massive fetal anemia and high-output heart failure. Fetal cardiac arrhythmias disrupt normal cardiac output and oxygen delivery to fetal tissues. Recognizing these patterns allows clinicians to identify high-risk situations early. Each category suggests different monitoring approaches and potential interventions to prevent or minimize hypoxic ischemic injury before it reaches the threshold for permanent brain damage. The developing brain demonstrates selective vulnerability to hypoxic ischemic injury, with specific regions and cell types showing differential susceptibility based on developmental stage, vascular supply, and metabolic demands. Understanding these vulnerability patterns explains why different clinical scenarios produce characteristic injury patterns. Cellular susceptibility varies dramatically with gestational age. In term neonates, neurons represent the most sensitive cellular elements to hypoxic ischemic insult. However, in preterm infants, both neurons and oligodendrocyte precursors demonstrate high vulnerability. This developmental difference explains why term and preterm infants develop distinct patterns of brain injury even with similar insults. Gestational age profoundly influences regional vulnerability. Hypoxic ischemic insults occurring before 20 weeks gestational age may lead to neuronal migration disorders like heterotopia or polymicrogyria because the insult affects the brain during active neuronal migration. Insults during mid-gestation, typically 26 to 36 weeks, predominantly damage white matter, leading to periventricular leukomalacia. Insults near term, at 35 weeks and beyond, result predominantly in deep gray matter injury or watershed pattern damage. The timing and nature of the insult determines the pattern of brain injury. Acute sentinel events like cord prolapse or uterine rupture typically occur within 10 to 46 minutes and predominantly damage the basal ganglia and brainstem while sparing higher cortical structures. These acute insults create the characteristic pattern we observe in infants who suffer sudden, complete interruption of placental circulation. Chronic or partial insults that develop over hours create different vulnerability patterns. These prolonged insults predominantly affect watershed territories, the parasagittal regions where arterial territories meet, and blood supply becomes most tenuous when perfusion pressure drops. This explains why infants with prolonged labor complications often develop cortical and subcortical injury in these boundary zones. Vascular territories play a crucial role in determining injury patterns. Watershed areas represent regions with the most precarious blood supply, located at the farthest points of arterial anastomoses. When cardiac output falls and perfusion pressure drops, these areas suffer injury first. The location of these watershed zones changes with brain development, explaining age-related differences in injury patterns. Understanding the clinical presentation of HIE requires recognizing that this condition unfolds as a dynamic process over time, not as a static snapshot. Think of HIE as a story that reveals itself in chapters, with each chapter providing crucial information for both treatment decisions and prognostic understanding. The timing of symptom manifestation becomes critically important for clinical decision-making. Symptoms typically appear within the first few hours after delivery. But here's where clinical expertise becomes essential. The clinical picture continues to evolve significantly over the first 72 hours of life. This evolution isn't random. It follows predictable patterns that experienced clinicians learn to recognize and interpret. The assessment window between 1 to 6 hours of age provides the most informative clinical picture for immediate treatment decisions, particularly regarding eligibility for therapeutic hypothermia. Why this specific time frame? During these early hours, the clinical examination reflects the direct effects of the hypoxic-ischemic insult before secondary complications develop or interventions alter the clinical picture. This window represents our clearest view of the primary injury before it becomes obscured by treatment effects or secondary organ dysfunction. The neurologic examination during this critical period reveals characteristic patterns. Infants with mild encephalopathy appear hyper-alert with wide-open eyes, often displaying what clinicians describe as a stunned look or blank stare. Their muscle tone increases, and they show heightened Moro reflexes that react strongly to tactile stimuli. In contrast, infants with moderate encephalopathy appear lethargic with decreased tone, weak suck reflexes, constricted pupils, and diminished Moro responses. Those with severe encephalopathy present as stuporous, with flaccid tone, absent reflexes including suck and gag, and poorly reactive pupils. Seizures represent one of the most significant clinical features, occurring in 56 to 88% of infants with HIE. However, understanding seizures in this population requires recognizing that most are subclinical, meaning they lack obvious clinical manifestations and can only be detected through continuous EEG monitoring. When seizures do manifest clinically, they often appear as subtle behaviors like apneic episodes, vital sign instability, abnormal eye movements, or repetitive oral facial movements, rather than the generalized convulsions we might expect. The multisystem involvement that accompanies HIE reflects the systemic nature of hypoxic-ischemic injury. Respiratory disturbances, including periodic breathing and apnea, commonly occur with moderate and severe HIE. Cardiac dysfunction, acute kidney injury, liver dysfunction, and coagulopathy frequently develop as consequences of the diving reflex that redistributed blood flow during the initial insult. Recognizing this comprehensive clinical picture allows clinicians to distinguish HIE from other causes of neonatal encephalopathy while making timely decisions about neuroprotective interventions. The SARNet scoring system provides a structured method for evaluating the severity of neonatal encephalopathy. It organizes clinical findings into 5 domains, each reflecting a different aspect of neurological function. Together, these domains support timely diagnosis and guide decisions about interventions such as therapeutic hypothermia. The first domain focuses on central nervous system function. Changes in consciousness, from hyperalertness to coma, along with the presence and frequency of seizures, reflect the extent of cortical and subcortical injury. These signs are often the earliest and most direct indicators of encephalopathy severity. Primitive reflexes are the next area of assessment. Reflexes such as suck, moro, and oculocephalic responses are mediated by the brainstem. Their weakening or absence suggests impaired brainstem function, which carries significant prognostic weight. These reflexes are also practical to assess at the bedside, making them valuable in early staging. Autonomic signs provide additional insight into the depth of neurological involvement. Pupil reactivity, heart rate patterns, and secretory activity are all regulated by deep brain structures. Abnormalities in these functions, such as bradycardia, poor light response, or excessive secretions, indicate disruption of autonomic control and often accompany more advanced stages of encephalopathy. Gastrointestinal motility, while less emphasized, contributes to the overall picture. Increased or erratic activity may reflect autonomic dysregulation and can complicate feeding and metabolic management. Though not diagnostic on its own, this domain supports the interpretation of other findings. Finally, neuromuscular tone and posture offer some of the most visually apparent signs of injury. Hypotonia, abnormal posturing, and the absence of spontaneous movement are strongly associated with severe encephalopathy. The presence or absence of myoclonus also helps differentiate between stages. Each of these domains contributes to a comprehensive clinical profile. The scoring system is designed to support early recognition of moderate to severe encephalopathy, which is critical for initiating therapeutic hypothermia within the recommended treatment window. The Thompson Encephalopathy Score provides a quantitative alternative to SARNet staging, using objective numerical scoring across 9 clinical categories. Each category receives 0 to 3 points, creating reproducible assessments that track changes over time. The scoring system evaluates muscle tone, level of consciousness, seizure frequency, posture, and primitive reflexes including moro, grasp, and suck. Additional categories assess respiratory patterns and fontanelle tension, providing comprehensive neurologic evaluation. The quantitative approach offers several advantages over subjective staging systems. Scoring remains objective and reproducible between different examiners, making it particularly valuable for research studies and clinical trials, where consistent assessment becomes critical. The system's ability to track changes over time proves especially useful during the first week of life when neurologic status evolves rapidly. Serial Thompson scores can document improvement or deterioration, guiding treatment decisions and prognostic discussions. Higher total scores correlate directly with worse neurodevelopmental outcomes, providing families and clinicians with evidence-based prognostic information. This correlation makes the Thompson score a valuable tool for both immediate clinical management and long-term outcome prediction. Both the modified SARNet exam and Thompson score serve as standardized methods for assessing HIE severity, with the choice often depending on institutional preference and whether objective scoring reproducibility becomes prioritized over traditional clinical staging. The 6-hour therapeutic window represents one of the most critical, time-dependent interventions in neonatal medicine. Secondary energy failure begins 6 to 8 hours after the initial hypoxic-ischemic insult, establishing the biological foundation for this narrow treatment window. The evidence supporting therapeutic hypothermia within 6 hours demonstrates remarkable efficacy. When initiated appropriately, cooling reduces death or severe disability from 65% to approximately 45%, yielding a number needed to treat of 7. However, studies examining delayed initiation between 6 to 24 hours show minimal to no benefit, with some suggesting potential harm. The pathophysiological basis centers on mitochondrial dysfunction becoming self-perpetuating once secondary energy failure begins. During the latent phase between 1 to 6 hours, cellular injury remains potentially reversible. Beyond 6 to 8 hours, inflammatory cascades reach critical mass and therapeutic targets become inaccessible to intervention. Clinical recognition poses significant challenges because infants may appear relatively stable during the latent phase. Secondary energy failure occurs during what clinically appears as stability, creating potential for false reassurance. Each hour of delay progressively reduces treatment effectiveness as cellular injury transitions from reversible to irreversible. Meta-analyses of randomized controlled trials consistently demonstrate that the therapeutic window cannot be extended. Studies attempting longer or deeper cooling or delayed initiation beyond 6 hours have shown no additional benefit. The biological constraint is absolute. Once secondary energy failure begins, neuroprotective mechanisms lose their efficacy. This evidence transforms HIE management from supportive care to urgent intervention. Recognition systems, transport protocols, and cooling initiation must operate with emergency-level efficiency. The 6-hour window demands immediate recognition, rapid transport, and prompt treatment initiation to optimize long-term neurodevelopmental outcomes. The natural progression of untreated HIE follows a predictable temporal sequence that correlates directly with underlying pathophysiological changes. Clinical encephalopathy reaches maximal severity during the first 6 hours, representing the optimal assessment window for treatment decisions. The transition at 6 to 12 hours marks the onset of secondary energy failure. Seizures typically begin around 13 hours of life in moderate to severe cases, with maximum seizure burden occurring approximately 4 hours after onset. Research demonstrates that each minute of seizure activity increases odds of abnormal outcomes by 2.2%, indicating seizures contribute actively to injury progression rather than serving merely as markers of severity. E.g., background patterns provide objective evidence of deterioration during the 12 to 72-hour period. Infants with initially normal or mildly abnormal patterns may show progressive deterioration after 20 hours, coinciding with secondary energy failure. Background patterns assessed at 48 hours demonstrate strong prognostic value, with persistently low voltage, burst suppression, or isoelectric patterns predicting poor outcomes. Peak cerebral edema occurs between 4 and 72 hours, corresponding to maximal cytotoxic and vasogenic swelling. During this period, mitochondrial dysfunction becomes irreversible, and inflammatory cascades reach maximum intensity. Neuroglial activation attracts peripheral immune cells through the disrupted blood-brain barrier, accelerating tissue destruction. Beyond 72 hours, the final pattern of brain injury becomes established. Conventional MRI sequences begin demonstrating structural changes, reflecting the completed evolution from functional to structural damage. At this point, the opportunity for neuroprotective intervention has passed completely. The clinical significance lies in recognizing that apparent stability during early hours masks ongoing cellular destruction. Without intervention, progression through these phases remains inevitable, emphasizing the critical importance of early recognition and immediate treatment initiation within the narrow therapeutic window. The biological basis for the 6-hour therapeutic window involves multiple cellular mechanisms that transition from reversible to irreversible injury. Secondary energy failure becomes self-perpetuating through mitochondrial dysfunction that progresses beyond the capacity for cellular recovery. Mitochondrial dysfunction initiates a cascade involving ATP depletion, membrane depolarization, and massive calcium influx. Elevated intracellular calcium activates destructive enzymes including lipases, proteases, and endonucleases that degrade cellular architecture. Calcium overload also stimulates nitric oxide synthase, generating reactive oxygen and nitrogen species that cause lipid peroxidation and further organelle damage. Inflammatory mediators overwhelm endogenous protective mechanisms through neuroglial activation following early neuronal death. This process releases pro-inflammatory cytokines and reactive oxygen species, attracting peripheral immune cells that enter through the compromised blood-brain barrier. The resulting inflammatory response creates a positive feedback loop, amplifying tissue destruction through both necrotic and apoptotic pathways. Excitotoxicity cascades reach critical mass when NMDA receptor activation and glutamate release become self-sustaining. Once this threshold is exceeded, intervention cannot effectively interrupt the pathological processes driving continued cellular death. Therapeutic hypothermia interrupts these pathways through multiple mechanisms, reducing cellular metabolism by 5 to 8% per degree Celsius, decreasing ATP consumption, stabilizing blood-brain barrier integrity, and reducing glutamate release and free radical production. Additional anti-epileptic effects limit seizure-mediated injury. The temporal limitation exists because these protective mechanisms require intact cellular machinery to function. Once mitochondrial dysfunction becomes structural rather than functional, and inflammatory cascades exceed endogenous regulatory capacity, therapeutic targets become inaccessible. Early intervention prevents progression to irreversible injury, while delayed treatment attempts to repair already damaged cellular systems. Understanding how therapeutic hypothermia protects the brain requires thinking about cooling as a comprehensive intervention that addresses multiple pathways of injury simultaneously. Rather than targeting just one mechanism, hypothermia works like a master switch that dials down several destructive processes while the brain recovers from hypoxic-ischemic injury. The metabolic effects form the foundation of hypothermia's neuroprotective action. Evidence demonstrates that hypothermia decreases cellular metabolism by 5 to 8% for each degree Celsius reduction below normal body temperature. This metabolic slowing creates a fundamental shift in the brain's energy balance. When cells require less energy to maintain basic functions, they can better survive periods when oxygen and glucose delivery remains compromised. Think of this as putting the brain into a controlled state of reduced activity, similar to how hibernating animals conserve energy during harsh conditions. Cellular protection mechanisms work hand in hand with metabolic changes. Hypothermia reduces ATP consumption and energy demands throughout brain tissue, allowing cells to preserve their limited energy stores for essential survival functions. The intervention also decreases glutamate release, which prevents the excessive stimulation that leads to excitotoxicity. Additionally, cooling stabilizes the blood-brain barrier, preventing the influx of inflammatory cells and toxic substances that would otherwise enter brain tissue and cause additional damage. The anti-inflammatory effects of hypothermia address one of the major secondary injury mechanisms. Cooling attenuates the inflammatory reaction and reduces cytokine production, including key inflammatory mediators like interleukin-1, 6, and 8, and tumor necrosis factor alpha. This reduction in inflammatory signaling helps prevent the cascade of immune-mediated damage that would otherwise continue for days after the initial insult. Hypothermia also provides anti-apoptotic effects, decreasing programmed cell death pathways that become activated after hypoxic-ischemic injury. This protection helps preserve neurons that might otherwise undergo delayed death through apoptotic mechanisms. The intervention reduces free radical production, including oxygen-free radicals and reactive nitrogen species that cause lipid peroxidation and membrane damage. The timing of these protective mechanisms explains why hypothermia must begin within 6 hours of birth. This therapeutic window aligns with the onset of secondary energy failure, allowing the intervention to prevent rather than treat established secondary injury processes. Determining eligibility for therapeutic hypothermia requires careful evaluation of specific criteria that identify infants most likely to benefit from this intervention while minimizing unnecessary treatment. These criteria emerged from extensive research trials and represent evidence-based thresholds for initiating neuroprotective therapy. Gestational age requirements reflect safety considerations and efficacy evidence. Current protocols require infants to be at least 35 weeks gestational age, though some centers use 36 weeks as their threshold. This restriction exists because historical studies demonstrated excess mortality in very immature infants who became hypothermic. The developing physiology of preterm infants makes them particularly vulnerable to the cardiovascular and metabolic effects of cooling, outweighing potential neuroprotective benefits. Evidence of perinatal acidosis provides objective markers of significant hypoxic-ischemic insult. The criteria include cord pH of 7.0 or less, or base deficit of 12 to 16 MEQ/L or greater. These biochemical markers reflect the severity of metabolic acidosis that develops during anaerobic glycolysis when oxygen delivery becomes inadequate. When cord blood gas analysis is unavailable, arterial pH less than 7.0 or equivalent base deficit within 60 minutes of birth serves as an alternative marker. The requirement for persistently low APGAR scores, specifically 10-minute APGAR scores of 5 or less, indicates ongoing compromise rather than brief perinatal depression that resolves quickly. This criterion helps distinguish infants with significant brain injury from those who experienced brief but reversible compromise during delivery. Clinical encephalopathy assessment using standardized tools like the Modified Sarnat exam or Thompson Encephalopathy score ensures that hypothermia targets infants with moderate or severe neurologic dysfunction. Mild encephalopathy generally carries excellent prognosis without intervention, while severe encephalopathy may represent damage too extensive for hypothermia to significantly improve outcomes. The critical timing requirement mandates initiation within 6 hours of birth. This window aligns with the pathophysiology of secondary energy failure, which begins approximately 6 to 8 hours after the initial insult. Starting hypothermia after this window misses the opportunity to prevent secondary injury mechanisms, significantly reducing therapeutic benefit. Additional considerations include the need for resuscitation lasting more than 10 minutes, which indicates severity of perinatal compromise, and the presence of acute sentinel events like placental abruption or cord prolapse that suggest acute onset hypoxic-ischemic injury. Implementing therapeutic hypothermia requires understanding 2 established cooling methods and the precise management protocols that ensure safe, effective neuroprotection. Both approaches have demonstrated equivalent efficacy in clinical trials, allowing centers to choose based on available equipment and expertise. Whole-body cooling represents the more commonly used approach in most centers. This method involves cooling the entire infant to achieve a target temperature of 33.5 degrees Celsius plus or minus 0.5. The precision of temperature control becomes critical because temperatures below 33 degrees Celsius may cause detrimental effects including cardiac arrhythmias, while inadequate cooling reduces neuroprotective benefit. Maintaining this narrow temperature range requires specialized cooling equipment with continuous temperature monitoring and automated adjustments. The duration of cooling follows evidence-based protocols established through clinical trials. Treatment continues for exactly 72 hours, a time frame determined by the duration of secondary energy failure and the optimal balance between neuroprotective benefit and potential complications. Shorter durations provide inadequate protection, while longer periods increase complication risks without additional benefit. Rewarming represents a critical phase that requires the same precision as the cooling process. Evidence demonstrates that rewarming must occur gradually at 0.5 degrees Celsius per hour over 6 or more hours. This slow rewarming rate prevents rebound injury that can occur with rapid temperature normalization. Animal studies showed increased seizures and cortical apoptosis when rewarming occurred too quickly, emphasizing the importance of controlled temperature transitions. Selective head cooling offers an alternative approach that combines targeted brain cooling with mild systemic hypothermia. This method uses a cooling cap perfused with coolant solution at 10 degrees Celsius applied to the infant's head while maintaining body temperature between 34 and 35 degrees Celsius. The theoretical advantage involves more direct brain cooling while minimizing systemic effects, though clinical trials demonstrate no significant efficacy differences between methods. The equivalence between methods allows centers to base their choice on practical considerations, including equipment availability, staff training, and institutional experience. Both approaches require specialized equipment, trained personnel, and protocols for continuous monitoring and management of cooling-related complications. Centers implementing therapeutic hypothermia must have comprehensive support systems, including continuous EEG monitoring capabilities, trained neurologists for seizure management, advanced neuroimaging with MRI, and access to subspecialty services for managing multisystem complications that commonly accompany HIE. Understanding therapeutic hypothermia's physiologic effects is essential for safe management during cooling. These changes follow predictable patterns that directly impact clinical care. The cardiovascular system responds dramatically to cooling. Heart rate decreases by 10 beats per minute for every degree below 37 degrees Celsius due to slowed conduction through the sinoatrial node. Cardiac output drops 7% per degree of cooling, primarily driven by decreased metabolic demands. However, myocardial contractility actually increases through enhanced myofibrillar sensitivity to calcium, creating an important compensatory mechanism that maintains tissue perfusion despite lower heart rates. Respiratory changes reflect altered gas physics during hypothermia. Minute ventilation decreases as metabolic demands drop, while gas solubility increases according to Henry's law. This means PCO2 decreases by 2 per degree of cooling, PO2 drops by 5 per degree, and pH rises by 0.015 per degree. These changes require careful interpretation of blood gas analyses during cooling. Metabolically, hypothermia achieves neuroprotection by decreasing cellular metabolism 5 to 8% per degree below normal temperature. This represents the primary energy-conserving mechanism that reduces oxygen consumption and ATP depletion during the secondary energy failure phase. Hematologic effects include increased blood viscosity and mild thrombocytopenia. Platelet function becomes mildly thrombophilic with increased aggregation, requiring monitoring for potential coagulation issues. Renally, glomerular filtration rate decreases while electrolyte handling becomes altered, necessitating careful fluid and electrolyte monitoring throughout the cooling period. Neurologically, cerebral blood flow decreases by 5% per degree of cooling, matching the reduced metabolic rate. Importantly, hypothermia provides anti-seizure effects, with studies showing significantly decreased seizure burden, particularly in moderate HIE cases. Successful therapeutic hypothermia requires vigilant monitoring and recognition of expected complications versus concerning adverse events that warrant intervention. Common complications during cooling are generally predictable and manageable. Sinus bradycardia represents the expected cardiovascular response to cooling and is usually benign unless heart rates become severely depressed. The 10 beats per minute decrease per degree of cooling helps clinicians distinguish expected bradycardia from pathologic rhythms. Thrombocytopenia occurs in many cooled infants, but is typically mild and resolves spontaneously. This reflects the hypothermia-induced alterations in platelet function and bone marrow activity. Platelet counts should be monitored, but intervention is rarely needed unless bleeding complications arise. Subcutaneous fat necrosis occurs in approximately 2.8% of cooled infants, typically appearing days to weeks after rewarming. This complication results from cold-induced crystallization of fatty acids in subcutaneous tissue. While concerning cosmetically, it generally resolves without intervention, though rare cases may require management of associated hypercalcemia. Monitoring requirements reflect the multisystem effects of cooling. Continuous core and skin temperature monitoring ensures precise temperature control within the narrow therapeutic range. Cardiac monitoring becomes crucial given the expected bradycardia and potential for arrhythmias. Blood pressure monitoring helps detect hemodynamic instability from the combined effects of decreased cardiac output and altered vascular resistance. Neurologic assessment and seizure monitoring remain paramount as seizure burden correlates strongly with brain injury severity and long-term outcomes. Continuous EEG monitoring is optimal, though amplitude-integrated EEG provides an acceptable alternative when full EEG isn't available. The critical contraindication involves avoiding overcooling below 33 degrees Celsius, which significantly increases arrhythmia risk. This narrow therapeutic window demands precise temperature management and experienced clinical oversight. Pharmacologic management during therapeutic hypothermia requires understanding how cooling fundamentally alters drug metabolism and clearance, creating the need for careful dose adjustments and drug selection. Hypothermia significantly reduces cytochrome P450 enzyme activity, the primary hepatic system responsible for metabolizing many commonly used NICU medications. At 34 degrees Celsius, drug clearance becomes dramatically impaired, with phenobarbital clearance reduced by 99%, phenytoin by 1%, and morphine by 25%. This represents altered enzyme kinetics rather than simply slowed metabolism, requiring clinicians to anticipate prolonged drug effects and potential toxicity. Specific medications require particular attention during cooling. Lidocaine and midazolam need dose adjustments due to significantly altered pharmacokinetics. Lidocaine becomes more effective for seizure control during hypothermia, but its clearance is markedly reduced, increasing the risk of cardiac toxicity if doses aren't appropriately modified. Traditional sedation approaches face new challenges during cooling. Morphine, while historically used, carries increased risks due to reduced clearance and potential for accumulation. The side effects of respiratory depression and hemodynamic instability become more pronounced when clearance is reduced by 25%. Dexamethasone emerges as a promising alternative for sedation during hypothermia. This alpha-2 adrenergic agonist provides effective sedation while offering anti-shivering properties that complement cooling efforts. Additionally, preclinical studies suggest neuroprotective effects, making it an attractive option for cooled infants requiring sedation. The altered glucuronidation pathways affect drugs like morphine that rely on hepatic conjugation for elimination. This creates cumulative effects that may not be apparent initially, but become problematic with repeated dosing. Minimizing polypharmacy becomes crucial during cooling, as drug interactions and cumulative effects become magnified when normal clearance mechanisms are impaired. Each medication decision should weigh therapeutic necessity against the risks of altered pharmacokinetics in the hypothermic patient.